So our speakers today, Dr. Anna Maria South was born in Germany. For medical school, she attended Budenschaft School of Medicine in Dayton, Ohio. She completed her residency in internal medicine at the University of Kentucky, where she now works as an academic hospitalist. She is passionate about treating patients with substance use disorders and also works on the addiction consult and education service as the attending physician at UK. Dr. Daniel Weaver went to medical school at the University of College Cork and then did his internal medicine residency at the University of Kentucky. He joined the University of Kentucky as a faculty member in the Division of Hospital Medicine in 2015 and started as a member on the Addiction Consult and Education Service at the University of Kentucky in 2018. Additionally, he is the medical director of Inpatient Medicine Consult and Co-Management Service at the University of Kentucky. So thank you for joining us today, and everyone welcome Dr. South and Dr. Weaver.
So thanks everyone for having us today. Dr. South and myself are here to present on opioid use disorder management in the hospital setting or the acute care setting. And it's really a great opportunity, I think, for patients when they're getting admitted to the hospital, because we consider it a recovery opportunity. Intro, we don't have any financial disclosures, and we're not going to make a bad joke about giving us money. So first, the practice gaps and educational needs. We need to recognize that a hospitalization is a recovery opportunity for patients with opioid use disorder. And it's important to improve the inpatient care of patients with opioid use disorder by initiating treatment for opioid use disorder while they're here and then optimizing their pain control. It's also important to learn how to reduce stigma in patients that experience, in patients with opioid use disorder that they experience while they're hospitalized. And then I think it's also important to review how to improve harm reduction education. So here are our learning objectives. We're going to review how opioid use disorder and hospitalization are linked. We're going to go through on how to diagnose and treat opioid use disorder during a hospitalization. We're going to learn to recognize and manage opioid withdrawal. We're going to perform a comprehensive risk assessment on our fake patient. We're going to optimize pain during her hospitalization here. And we're going to talk about learning how to eliminate stigma. And I think this is an ongoing process that even myself, I continue to learn about and work on. And then also discuss some harm reduction strategies. So our expected outcomes, we're going to hopefully improve care for patients admitted to the hospital with opioid use disorder. We're going to do this by assessing their risk, managing their medical condition, as well as their opioid use disorder, which is their other medical condition, and then control their symptoms related to the opioid use disorder, such as pain and opioid withdrawal, and then learn to eliminate stigma. So we'll start with our fake patient that's modeled over a number of patients that get admitted. Her name is Danielle. And we're going to revisit Danielle throughout the presentation and refer to her. She's a 23-year-old woman that presents to the hospital with 3 days of fevers, chills, shortness of breath, and lower back pain. Her past medical history is notable for viral hepatitis C. She's had past cellulitis of her forearm that has required an incision and drainage. She uses tobacco products, opioids, and methamphetamines. And her labs are notable for an elevated white count or leukocytosis and a mild acute kidney injury. So we'll come back to Danielle, but first I'd like to inundate you with some statistics about opioid use disorder and its rise in the United States. And this first slide shows the increase of drug treatment admissions reporting injection of any opioids. And you can see from 2004 to 2014, there was a substantial increase in the rate between the age groups of 18 to 29, as well as 30 to 39. And you can see kind of running parallel to that is with the increase in injection use, the increase of viral hepatitis C also increased. And it was estimated in 2016 that about 2.4 million people had opioid use disorder in the United States. And of those patients with opioid use disorder, only 20% received any treatment. And among those 20%, only 37% of those received any FDA-approved medications, which is the gold standard for treating opioid use disorder. So that's only about, if you do the math, about 7% of patients. Here's another graph that shows the increase in drug overdose deaths involving any opioid. And you can see from 1999 to 2010, it nearly doubled, just below 10,000 to over 20,000. And then you can see from 2010 to 2019, you had it approaching 50,000. And if you're paying attention to the headlines recently, we may have approaching 90,000 in 2020. So another spike in overdose deaths. One of the reasons why we're having so many more overdose deaths, I think, other than maybe the isolation related to COVID-19, is the drug supply in the community. You can see starting in 2015 and going up to 2019, the drug overdose deaths, this orange line shows that synthetic opioids, mainly fentanyl, has contributed to overdose deaths. So with the rise in opioid use disorder and increase in overdose deaths, we can see an increase in healthcare utilization for inpatients. And this is a graph that shows from 2005 to 2014, there's a steady rise in opiate-related inpatient stays and ED visits. So patients coming with injection-related infections, potentially, or overdoses to the ER. And here's another map that shows the density of inpatient stays. So in 2017, the national rate of opioid-related inpatient stays was around 299. And we can see here in Kentucky, we're in the highest or the darkest blue bracket and greater than 350. And actually, if you look at the numbers, it's, I think, 415 in 2016 and then 445 per 100,000 in Kentucky alone. This is another graph that kind of just shows the highlight of healthcare utilization and inpatient stays for patients with opioid use disorder. So what patients are getting admitted with? They present often to the ED with injection-related infections as well as overdoses. So this is a graph that showed from 2002 to 2012. So it doesn't quite capture that spike in overdose deaths that we've seen and the rise in opioid use disorder since 2012. But you can see that there was an increase in opioid abuse with infection, infective endocarditis, osteomyelitis, septic arthritis, or epidural abscess, or to put it simple, infected heart valves, infected bones, infected joints, or I guess pus on the spine. Here's another graph from a study in Pennsylvania that showed the increase in drug use, so that's DU, associated infective endocarditis. It shows kind of since 2015, you can see the spike increasing to 2016, 2017 of infective endocarditis increasing in patients that use drugs. So just to cap it off with other trends, another study showed that an increase in 38% of discharges documenting opioid use disorder. Another study showed that patients with chronic pain showed an increase in opioid use disorder diagnoses. And even women that deliver children showed a quadrupling from 1999 to 2014 in the diagnosis of opioid use disorder. So I hope with all that stats, you believe me that there's an increase in opioid use disorder, as well as there's high healthcare utilization with these patients. So because there's such high healthcare utilization with patients with opioid use disorder, it's really important to learn how to care for them better while they're here in the hospital. And I think initially it's important to learn how to diagnose and treat opioid use disorder, to learn how to perform a comprehensive risk assessment, to manage opioid withdrawal, to optimize pain, and to eliminate stigma from providers while they're caring for patients with opioid use disorder. I think it's also important to learn how to manage ambivalence and provide some harm reduction strategies for patients that aren't, quite ready to quit or do exactly what doctors think they should do. So first, how do you diagnose opioid use disorder? It's the first step in providing effective intervention and care. Initially, you want to perform a quick screen. If that's positive, you want to conduct a non-judgmental clinical evaluation where you ask patients about their history of drug use, the frequency of use, the amount and route of use. And then you can diagnose them using the DSM-5 criteria. So a quick screen, a lot of providers learn this when they're going through medical school, if they're or nurse practitioner school, part of their social history, asking about drug use. And I think it's important when you ask this question to do it in a non-judgmental manner, so you're more likely to get a true answer. And so you can ask a question: how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? That's one way to do it. There's also screening tools that exist, and this is a screening tool, the NIDA Modified Assist. And so you could ask, in the past year, how often have you used the following: alcohol, tobacco, prescription drugs for non-medical reasons, or illegal drugs? So that's another screening tool that exists. The way to diagnose opioid use disorder is using the DSM-5 criteria. And there's three, areas in the DSM-5. There's the physiological sequelae that includes tolerance, withdrawal, and cravings. There's the loss of control, that is the greater amount of time than intended, persistent desire to cut down but unable to, excessive time getting, using, and recovering from use. There's adverse consequences, which include failure to fulfill responsibilities, use in physically hazardous situations such as in a locked room or alone, disruption of social and interpersonal problems like conflicts with family members or loved ones, given up or decrease other important aspects of life. I've had a patient who told me once that he was really interested in fixing cars up, and he no longer was able to do that because his drug use had consumed his life. And then ongoing use of opioids despite these problems. And then checking on the number of boxes, you can, 2 to 3 would be a mild opioid use disorder, 4 to 5 would be a moderate, and greater than or equal to 6 would be a severe opioid use disorder. I think initially looking at this slide, it could be very challenging to remember all these things. So I think, to put it simply, you could ask how a patient's drug use has affected their life. Ask them about withdrawal and cravings, and just how their use has changed over the number of times that they've been used. And I think you'll actually get a lot of these answers without asking the specific question. Has it caused any conflict in your life? And actually, a good opening with any patient is just asking them what they're interested in, what they like. Do they like working on cars? Are they into sports? And then you can form that connection with them, and then go back to it and ask them, are they still able to do those things that they used to be interested in? So we can go back to Danielle. So she's the 23-year-old woman that presented with fevers, chills, shortness of breath, and lower back pain. She has the viral hepatitis C and previous cellulitis. She uses tobacco, opioids, and methamphetamines. And then she has a elevated white count, which makes us concerned for an infection and a mild acute kidney injury. So you ask Danielle about her drug use, and she tells you, she's really forthcoming, that she's been using heroin and fentanyl for the past year, multiple times a day. And about 3 months ago, she transitioned to injection use because it wasn't having the same effect. She wanted it to last longer, her supply. When she's unable to obtain heroin, she says she gets dope sick, or she goes through opioid withdrawal. And that's when she uses her methamphetamines to make her intoxicated, so she doesn't feel the ill effects of the withdrawal. She tells you she craves it. She's definitely been using longer than she wanted to. She's tried to quit, but she's unable to stop, and she continues to return to use. She's lost her children, because of her drug use, and she's really sad about this, but she continues to use, and this really has disappointed her, unfortunately. One of her main worries in the hospitalization is opioid withdrawal, and she tells you about this, and she's really worried about her hospitalization because it's really an unpleasant feeling she feels. So you ask Danielle about her drug use. She tells you, when you have a patient that injects drugs, you want to be concerned about regular infections, but then injection-related infections as well. And so the things that we think about are cellulitis, infective endocarditis or infected heart valve, osteomyelitis, so infected bones, septic arthritis, so an affected joint, or an epidural abscess. And those are in the one slide from 2002 to 2012 that all had increased in patients. So you want to ask Danielle also about her risks and perform a risk assessment. So you ask her about her injection sites, so you know where to examine later. You ask her about, does she share needles? Does she reuse needles? What's her source of water? Does she use sterile water? Does she boil the water? Does she clean her skin with alcohol? Does she have access to naloxone? Has she had private overdoses, and how many? Where does she use? Does she use alone or with others? Does she use in a locked bathroom? Because that can be quite dangerous. You'd like to ask about trauma history as well as active trauma. You want to ask her if she engaged in transactional sex. And then you would want to check her Casper to see maybe if she's been on medicine before or if she's been prescribed opioids. So you've done her risk assessment. She's told you her use history. Then you want to do your general physical exam, but also you want to keep in mind her potential for injection-related infections. So you want to listen to her heart to see if you can hear a heart murmur. You want to evaluate her skin and injection sites to see if there could be an abscess there or a pocket of pus. You want to feel her spine to see if their infection could be there. You want to look at her teeth to see if there could be any poor dentition or potential abscess there. And you want to listen to her lungs as well. In terms of testing after you examine her, you definitely want to do a urine drug screen because really she's probably not aware of exactly what she's using, and you certainly are not either. And so that helps. Sometimes it helps even counsel patients on, if you have a urine drug screen with fentanyl, and you want to let the patient know that there's fentanyl in their urine, because really the fentanyl has increased the risk of overdose. You want to check her for STIs, sexually transmitted infections. You want to check her for hepatitis A, B, and C, so you can potentially vaccinate her for A and B. You want to see if she's pregnant. You want to check blood cultures to see if she's growing a bacteria in her bloodstream. Potentially, you'd want to order an echocardiogram to see if she has an infected heart valve. And then you'd want to do a panorex or an x-ray of her mouth to evaluate for a dental abscess. So this is Danielle's history, and we highlight the bottom line is because withdrawal is one of her main worries with this hospitalization, and that's really a big concern for patients with opioid use disorder. And because it's such a concern, it's really important to highlight that. And I think this is a portions of care with patients with opioid use disorder that's underappreciated by a lot of providers. Opioid withdrawal can experience a wide range of symptoms in the acute phase with a cessation or reduction of opioid use, but it causes a lot of discomfort in patients. And this is really what prompts patients to return to use. And if you talk to patients, a lot of times they don't use opioids anymore to get high or have the euphoria, but they use to feel normal or not get dope sick. And so this is really what drives a lot of return to use. And it causes a lot of conflict in the hospital if a provider or a doctor or nurse don't recognize that. A patient with inappropriately or inadequately treated opioid withdrawal in the hospital is torn between wanting to get their infection treated in the hospital, but also not feeling profoundly sick because they came to the hospital to get better. So it's really important for providers to recognize this and treat it appropriately. The other aspect of chronic opioid withdrawal is the altered physiological function that lasts longer, up to 26 weeks or longer. And this can also precipitate a relapse. And it's just important to keep that in your mind. And so you know that you're aware of it. So once a patient is out of acute withdrawal, there's still other things that could potentially make them return to use. So how do you recognize opioid withdrawal? Well, there's the clinical opioid withdrawal score, or COWS score, and has a number of items such as increased heart rate, sweating, restlessness, pupil size if they're dilated, myalgias, GI upset, or gastrointestinal upset, tremor, yawning, anxiety, and goose flesh. And based on the scoring system, you can rate the severity of opioid withdrawal. what's a little tricky is in the hospital, people are usually sick for some reason. And so there's other things that can kind of make it challenging to recognize opioid withdrawal and separate that from maybe infection. So the things that separate it in the hospital that we look for are often the pupil size, yawning, tearing, that type of thing. The heart rate and sweating, those can happen with infections as well. So how do we manage opioid withdrawal? I think the important part is to say treat them with medicine for opioid use disorder with buprenorphine. This is done quite infrequently. Thankfully, at the University of Kentucky with the ACEs team, we are doing this more and more, but it's still nationwide. It's done infrequently. Other medications other than buprenorphine are methadone as well. It's important that these two medications, some studies show that patients on these medications, when they come to the hospital, are less likely to get readmitted to the hospital. Other ways to treat opioid withdrawal are with just simple opioid agonists. And I think a lot of doctors are worried that giving medications like oxycodone and morphine to patients with opioid use disorder in the hospital will make their opioid use disorder worse, when that is false. It won't really change their opioid use disorder. It would just help manage their opioid withdrawal. There are medications available to help with symptom management. So first, we'll go through the steps on how we initiate Suboxone or buprenorphine in the hospital. We need patients to be in moderate opioid withdrawal. And I like to say we're curing the mild or moderate opioid withdrawal with their buprenorphine. So you want to stop all opioid analgesia. So either you started them on some sort of morphine or oxycodone beforehand, and you want to hold it and then wait at least 8 hours. So they're in mild to moderate opioid withdrawal. Also, you could ask them when their last use was, and then start to monitor their clinical opioid withdrawal score, and then cure their opioid withdrawal with buprenorphine. So this is our protocol here in the hospital. We stop the opioid agonists like oxycodone or morphine, and then we wait 8 to 12 hours and monitor their clinical opioid withdrawal score. And when it's high enough, greater than 8, we cure their opioid withdrawal with buprenorphine 4 milligrams. Then we continue to monitor them, and we dose them throughout the day if needed. So day 2, we consolidate day 1's dose, we give it to them in the morning, and continue to monitor them. And we may give them another dose if they still are scoring high enough on the clinical opioid withdrawal score. And then day 3, we kind of consolidate day 2's doses into once a day in the morning. Methadone we also start in the hospital because it is the standard of care for decades. It has been shown to increase retention in treatment, reduces the rate of opioid positive urines, and has been shown to decrease all-cause mortality. Unfortunately, there are a lot of barriers to care for patients with opioids. So really, when a patient comes to the hospital, if they're not already in a methadone clinic, we want to make sure that they're able to get into a clinic. And so we really go through the barriers to make sure they're able to do it, because we want to set them up for success. And so, the availability of methadone clinics, they're not everywhere in the state. We want to make sure that a patient can get to the methadone clinic. We want to make sure that they have identification, that they have insurance, or they're able to fund the methadone, that they're able to go to the clinic every day. If a patient lives in a rural area, the closest methadone clinic is 2 hours. 4 hours a day going to a methadone clinic can be quite challenging, and we have to make sure that they realistically will be able to do so. And also, there's long wait lists too. Medically, one of the challenges is that it prolongs something called the QTC, which is an interval on a heart tracing essentially. And if it gets too long, a patient can go into a fatal heart arrhythmia. We don't want to do that, so that would cause more harm than good. So it's something we do. We do a heart tracing before we start methadone, and also while they're on the methadone here in the hospital. So again, we obtain that EKG, and then if it's appropriate and they're able to go to a clinic every day, we would start them on methadone, about 30 milligrams the first day. We use liquid because it's less likely to be diverted. And we can split the dose here in the hospital during the day, but when they go back As an outpatient, they would need to do daily dosing once a day. In the clinics, in the methadone clinics, they usually only increase the dose every 5 days because it's a very long-acting medication, and it takes some time for it to build up in your system. The third thing to do, other than regular opioids for opioid withdrawal, is treat their symptoms. And you can do this in addition to opioids. Is give them medications for their nausea, like Zofran or Reglan. You can give them medications for their diarrhea if they don't have a diarrheal infection, Imodium or loperamide. You can give something for anxiety, irritability, or their sweating, clonidine. For their insomnia, you can give them trazodone or diphenhydramine. And then for their pain, it's important to include NSAIDs. Dr. Soft will talk about that more. So going back to Danielle, she has with her workup, you found that she has an epidural abscess with some spinal cord compression. She needs to have that abscess drained. Interventional radiologists have graciously agreed to put her on their schedule. She also has been found to have infective endocarditis with an aortic valve abscess, and she needs a valve replacement. However, she's hemodynamically stable, and they plan to do that next week. And they would like to extract her teeth to minimize the future risk for infection. But we just started Danielle on Suboxone, and so a lot of concern is, what do we do about the Suboxone now that she, with all these painful procedures coming up? And this is where Dr. Soft will take over.
Thank you, Dr. Weaver. So this is a question that we get a lot of times on the ACES service, the Addiction Consult and Education Service, is a patient's opioid withdrawal has been treated with buprenorphine, but now because they're in the hospital and they have medical complications from their use, as the infections that Dr. Weaver mentioned, they now have to also undergo painful procedures. And a lot of times our consulting physicians ask us to help them with that during the hospitalization. So this is something that we run in a lot, right? Our fictional patient, Danielle, was concerned that she was going to be going through opioid withdrawal. Another concern that we hear frequently from patients is that they are in pain and that their pain is not adequately managed by physicians or other providers while they're in the hospital. And these are patients that are opioid tolerant. And we put this on our slide here twice because it's really important for providers to understand that these are patients that need higher doses of full agonists compared to somebody that is opioid naive. And sometimes these doses can be quite high and honestly be scary for a provider to be prescribing to a patient. And that's when we encourage providers to remember that this is a patient that's being monitored on the floor. So we are watching closely for sedation. Nursing staff is really good about that. So we need to make sure that we are adequately treating their pain while avoiding sedation. And if we do not adequately dose full agonists, and a full agonist is something like oxycodone or morphine that works similar to, for example, heroin or fentanyl that a patient would be using from the street. So if those are not adequately dosed, a patient is going to experience withdrawal and their pain is not going to be adequately treated. There is some medications like long-acting agonists, for example, extended release morphine, extended release oxycodone called OxyContin. And a lot of our patients, depending on what they're going through, will need extended release pain medication initially for pain management, with shorter acting medications like oxycodone or morphine for breakthrough. Another thing that I really always emphasize with other providers is that our patients are also at risk of losing their tolerance. And that can happen in a fairly short amount of time, sometimes even in days. And patients are at high risk of experiencing an overdose and dying from an overdose if they lose their tolerance. And a lot of times we see that happen in patients when they leave either the hospital or a jail. And this is really an opportunity for us in the hospital to educate other providers so that we can make sure our patients are not put at additional risk when they leave the hospital. And the other thing is too, a lot of times patients feel like a lot of their autonomy is taken away when they're being hospitalized, because even simple things like when they can go outside, when the lunch dinner comes, is out of their control. And they also feel that a lot of providers make decisions about pain management without involving them into this important discussion. So what we want to do also is talk to our patients and make sure that we take their pain serious, and that just because they have an opioid use disorder, they still have pain, and that pain deserves to be managed adequately. And at the same time, we will treat their withdrawal. So those are some important messages that we want to get across to our patients, and we want to involve them in that decision making. Depending on where they are having pain, there's different ways to manage it. Something to consider could be, for example, a local block, especially if someone is having very localized pain, for example, in their teeth. Another thing to consider is, even though our patients need opioids to treat their withdrawal, don't forget about non-opioid pain medications. So those are NSAIDs like ibuprofen. Our patient Danielle, she does have a kidney injury when she comes in, secondary to her infection and dehydration. So that's something you obviously want to watch out for. Tylenol is another great medication if they're not in liver failure. Lidocaine patches. So those are all over-the-counter things that we can prescribe here in the hospital to treat patients' pain. And then don't forget about the non-pharmacological ways to treat pain, and really use a multidisciplinary approach when you treat patients' pain. Here at UK, especially with COVID precautions getting a little bit better, we are very lucky that we have a lot of different things available to us to approach the patient. So heat and ice is actually now built into our admission order set that we can order when the patient arrives in the hospital. We have a massage therapist that comes, and unfortunately there's only very few of them and a lot of patients that would benefit from that, so that's limited resources. But physical therapy can be very helpful to work with our patients and show them stretches that can relieve certain painful areas as well. Music therapy, I really love music therapy because they come into the patient's room and a lot of times let them choose their own songs. Patients sing along, and it gives like a great opportunity for a creative outlet too, especially during a very stressful time like a hospitalization. And they also write good notes in the chart for us to see, and this gives us a different perspective on a patient. Rather than just seeing the disease, we actually get to see some of the things that they enjoy outside the hospital. Narrative therapy, as Dr. Weaver mentioned, a lot of our patients are going through a lot of trauma or have a history of trauma, and talking through that helps a lot of our patients. We have service animals, so we have dogs that come and can play with our patients, and then we also have acupuncture as well. So going back to our fictional patient, Danielle, the first thing of her long procedures that she's gonna have coming is the teeth extraction. So as Dr. Weaver mentioned, the point of that is to try to minimize future infections, especially because when her heart valve is getting replaced, that is a high risk for reinfection in general. So the teeth extraction, the way I think about the procedures is this is something that is quote unquote a smaller procedure that could technically be done outpatient. A lot of us get, our teeth taken care of outpatient. So this is a procedure that, while pain is associated with it, out of the other procedures that she's going through compared to them is less painful. So for that, we would continue her buprenorphine naloxone. So the Suboxone would be continued during that procedure. And some things that I would talk to her about would be, we can split the dose. Suboxone unfortunately doesn't taste very pleasant. And that is a lot of times the limiting factor to why patients don't want to split the dose. But it does have a good pain management effect as well. So it has a long half-life that lasts for a long time if you're taking it for opioid use disorder, but the pain management usually lasts about 4 to 6 hours. So we talk to our patients about splitting this medication. Most patients opt to do it twice a day. And like I said, the taste is the limiting factor. But some people, like to take it 3-4 times a day in an acute setting like this, where they have acute pain that needs to be managed. And then I would discuss with Danielle that we should also add the non-opioid pain medications, as long as there's no other medical contraindications. So Tylenol, ibuprofen, and then, music therapy and all this stuff to distract her while she's going through that as well. With the teeth, it's a very localized area, and depending on how many teeth, for her in this scenario, it's a total extraction, but you can consider a local block as well. And the dentists do that a lot. Depending on other body areas, you might have to get anesthesia involved. And like I said before, this is a big decision for our patient. So we want to discuss this with our patients before they undergo the surgery, so they know that there's a good plan in place for pain management. Next, we're coming to the second scenario, and this is a little bit more painful. So now she has an epidural abscess. As Dr. Weaver explained, that's a collection of pus that's forming around the spine that needs to be drained. And that involves, breaking the skin and going into the area around the spine. So as you can imagine, that is a little bit more painful than a teeth extraction. And for us in the hospital, we consider this a moderate level of pain procedure. So this is something where somebody that is opioid naive and would have this done and does not have an opioid use disorder probably would be prescribed opioids as well for pain management. Whether this was done in an outpatient or inpatient setting for somebody that does not have an opioid use disorder, they would probably get full agonists, so oxycodone or something to treat their pain. So in this case, what we want to do is we want to add full agonists on top of the buprenorphine. So buprenorphine is, and this is a little bit technical, but it is a partial agonist of the mu receptor, the opioid receptor. So it binds very tightly to it. And what happens is if somebody has used opioids and is opioid dependent, and this opioid receptors are saturated with full agonists such as morphine or heroin, and the Suboxone comes in, it will actually go onto the receptor and kick off the morphine and send the patient into precipitated withdrawal and make them very sick. So basically somebody goes from feeling normal to acute severe withdrawal in a matter of minutes. And as you can imagine, it's a very unpleasant experience. And that's why Dr. Weaver talked about us usually leaving a period of time between the last opioid use and initiating Suboxone. And a lot of our patients, when we tell them that they can, on top of their Suboxone, have other agonists like oxycodone, get very scared that they're going to experience precipitated withdrawal. So that's when it's important for us to explain that the Suboxone binds so tightly to the receptor that the oxycodone or morphine or any other full agonist is not going to have the ability to knock it off the receptor. And since it's a partial agonist, there's still availability on the receptor that is open that the full agonist can bind to. So they are still going to be able to experience pain relief. And that's a very technical discussion to have with a lot of our patients, especially when they're in distress and have fear over an upcoming surgery. So what I do a lot of times is I either use my hands to explain how stuff gets knocked off and how it's a partial and there's still availability on the receptor, or I will draw them a picture in my very poor drawing skills on their whiteboard so that they have it available and can reference it as the surgery gets closer. So since the buprenorphine has a steady state in their body, is what we call it, they are not going to experience precipitated withdrawal. But since the receptor is partially saturated, once again, that's a situation where a patient might need higher doses of full agonists, so oxycodone or morphine, in order to experience adequate pain control. So this is very important that as a provider, I go back into the room and make sure that the pain is actually controlled and increase opioids if needed afterwards. And once again, I don't want to forget about my non-opioid pain management options like Tylenol, NSAIDs, all those things. And then I want to talk to Danielle before her procedure and make sure that she knows this is not our forever game plan. We're not planning on discharging you from the hospital with oxycodone. This is a temporary, time-limited situation to get you through this acute process. And, we will wean you off the opioids and then reassess later how your pain is being treated. Because a lot of times for our patients, it is scary to think, they are early in their recovery process. They have just been initiated on medication for opioid use disorder. And now, we're reintroducing opioids. So that is a very scary time for a lot of our patients. And they're very concerned a lot of times that they will start using again. And then the big one, the valve replacement. So that basically means that the heart surgeons are going to go into a patient's chest and, so to speak, crack the chest open and take out the infected heart valve and put a new heart valve in. So as you can imagine, out of all the procedures that we discussed, this is the most painful one. And that is usually a case where we would recommend to stop the Suboxone. So we would stop the Suboxone before the surgery in order for the opioid receptors to free up so that a patient can actually get full opioid agonists like oxycodone or morphine and get the full benefit from it. And unfortunately, in the hospital, a lot of times we don't get a lot of notice of when a surgery is planned. Like the surgeons will pick a date and, depending on OR availability, it gets moved around. So what we usually do is we hold the Suboxone the morning of the surgery. But if this is an outpatient procedure for whatever reason and it's planned longer, there's also the opportunity to maybe taper the Suboxone prior to the surgery. And this is a time when we once again want to start full agonists for pain management. So once again, oxycodone or morphine. And in this situation, those full agonists serve two purposes. The first one is to hold off withdrawal. We're stopping the Suboxone, a patient is going to start withdrawing from it. So we want to give them full agonists to saturate those receptors. And then the second purpose is obviously, as I mentioned, pain control, especially after the procedure. Once again, continue the non-opioid pain medications. Unfortunately, we get a lot of calls from primary teams that are saying, we cannot control this patient's pain. And we look through their chart and all they are on is opioids and they are not on anything else. So that's a good opportunity for us to do some education and say, they still, all these things still work on different receptors and different pathways in the body. So patients still benefit from having Tylenol added and from having ibuprofen added on top of everything else. And this is once again a situation where I would see a patient very often in the hospital, maybe even daily, to talk to them about how things are going and when we're going to restart the buprenorphine. A lot of times, if there's no complications from the valve replacement, usually post-op day 3, so 3 days after they've had their surgery, is when we restart the Suboxone. And they would have to go usually through an initiation protocol again. So they have to be able to tolerate a short period of withdrawal or washout from the opioids. There is also a way to microdose patients, but that is a completely big topic as well that we can talk about at some other time. But in general, with a traditional induction, they would have to have a washout period. So usually, I tell the patients before they even go into the OR that, maybe post-op day 3, we'll talk about restarting your Suboxone, depending on how things go and how you do. As I'm sure a lot of you know, buprenorphine, or the medication that's in Suboxone, is also available as an extended release form. The trade name for that is called Sublocade. And we can actually administer that usually on the day of discharge in the hospital as well, as long as we have a long enough lead up time to know when the patient is getting discharged. So that goes into the sub-Q fat area here in the abdomen, is demonstrated in the picture. It usually lasts about 4 to 6 weeks, and it's equivalent to about 16 milligrams of the sublingual product, the product that goes under the tongue. And the Casper, so that's the report that we pull from the Kentucky system to see what controlled substances a patient has been prescribed, will also still show up that this patient has received buprenorphine. So when you see a patient in clinic, if we gave them Sublocade here in the hospital and you pull that Casper, you will see that we did give them the Sublocade. If this is a patient has received Sublocade in the outpatient setting and then gets hospitalized and for whatever reason has to undergo a surgery, so sometimes we see, our patients get into motor vehicle accidents or, have some sort of other trauma that just like happens to everybody, and they come in after they've received their Sublocade, then pain control can be a big issue. And we once again need to remember that part of their receptors are saturated by the buprenorphine and they need opioid tolerance, so higher dosing of pain medication. As Dr. Weaver mentioned, we do start patients on methadone as well in the hospital. And of course, those patients will also maybe have some procedures that they undergo, just like Danielle, who is on Suboxone in our scenario. The issue that we run into a lot of times in the hospital is that methadone, as Dr. Weaver mentioned, is dispensed daily in the treatment facilities. So it's not a script that a patient physically has in hand, and therefore does never show up on their Casper if it's prescribed for opioid use disorder. Some patients, we see cancer patients too, that are prescribed methadone for pain management. For them, it will show up on their Casper. So a lot of times physicians or nurse practitioners, PAs, will have a patient that will tell them they're on methadone. They will pull the Casper and the Casper is blank, which would be appropriate for the patient, but it confuses the providers and they think that the patient is not quite forthcoming with them. So what we advise for our providers to do is to call the methadone clinic and verify, obviously this is all with the patient's permission. So you have to ask the patient's permission to call the clinic and then verify that the patient is actually being seen there as a patient, and then call them to see when were they last seen and what dose of methadone were they on. And a challenge of this in the hospital is, a lot of times people round on their patients early and then in the afternoon they want to do all the follow-up calls and, take care of the orders and everything, but by then the methadone clinic is closed. So it's important for our providers to understand that they have to call the methadone clinic first thing in the morning before they close so that they can actually get information on that. We typically advise that as long as it's safe for the patient to continue them on the methadone dose that they are maintained on in the outpatient setting. An exception for that would obviously be if a patient has severe respiratory compromise or is so encephalopathic that we don't feel like it's safe for them to have the medication, and then we would decrease the dose. If a patient comes in and is intubated, so that means if they're being hooked up to a breathing machine and are artificially ventilated, we do advise for the methadone to be continued. A lot of times they will have a feeding tube through their nose as well, so that's where the methadone can be given. Because otherwise it's very hard to achieve adequate sedation for a patient that's being artificially ventilated. As you can imagine, that's really uncomfortable. Like I said, we want to continue the same dose as outpatient as long as it's safe for the patient. If a patient has acute pain, we do not advise to rapidly up titrate the methadone. As Dr. Weaver said, it does affect the heart and it can cause arrhythmias. So heartbeats that are abnormal and they can actually cause the heart to stop beating if a methadone is up titrated too quickly. So what we don't want is for someone to say, oh, they are having acute pain, I'm just going to double their methadone dose and treat their pain that way. No, continue the current dose. If you want to, you can split the current dose in multiple per day dosing to kind of capitalize on that analgesic effect as much as possible. But then in addition to that, add short-acting opioids. So something like oxycodone for breakthrough pain. And then of course, don't forget about your non-opioid pain medications again, like the Tylenol and NSAID. I feel like I'm a broken record driving this point home. And then you want to monitor your patients for sedation while you are giving them the long-acting methadone in addition to the short-acting breakthrough agonists for pain. And just remember, this patient needs an EKG. So that's the tracing of the heart that Dr. Weaver mentioned. And why that's so important is even though they're stable on their dose outpatient and are tolerating that well in the outpatient setting, in the inpatient setting, we are introducing new variables to the patient. For example, antibiotics, anti-nausea medicine, and those can all cause that QTC that Dr. Weaver mentioned, the conduction system in the heart, to prolong, which puts them at higher risk for a fatal arrhythmia. And obviously, our number one priority is to keep our patients safe while they are under our care. And, if we initiate methadone on somebody in the hospital, Dr. Weaver has already mentioned there's a lot of barriers that we encounter. And that's especially if a patient's hospital course is unpredictable. So there's a limited amount of methadone clinics in the state because they have to be authorized by the federal government. So I could not just go and open up my own methadone clinic to meet the need of the Kentucky population. And it gets dosed every single day. So if a patient's discharge date is not known to us, it is very hard for us to arrange for next day follow-up. And legally, I'm not allowed to discharge a patient with a prescription of methadone in hand. So they really need that next day follow-up. In addition, a lot of the clinics have limited intake days. So for example, some clinics might only do intakes on Tuesday, but our patient has 6 weeks of IV antibiotics scheduled that finish, for example, on a Thursday. So now I know as a provider that I cannot discharge the patient on Thursday and have them get dosed on Friday because they won't be able to go for their intake appointment until the next Tuesday. So that leaves them for several days without medication and puts them at high risk for relapse and starting to use again. And that's when we really work with a primary team, especially if we know in a few weeks in advance that we're going to run into this scenario. So we're going to try to maybe reschedule their antibiotics. So for example, to have them finish the evening of Monday so the patient can be discharged Monday evening and then go get dosed on Tuesday. Or we talk to them and see if they are willing to keep a patient in house for an extra 2 or 3 days to get dosed. And as long as the patient is willing to stay, to do that so that then a patient can go to their follow-up the next day. And the other situation that we run into too is if a patient was already established at a methadone clinic and then all of a sudden they don't show up for a few days, they might get discharged from the methadone clinic because they don't know that the patient is being hospitalized and is receiving, care from us. And that's why they're not going to the clinic. So it's very important for us to remember that and provide patients proof of their hospitalization. And what we usually do is we give them their discharge paperwork that shows you were admitted on this day, discharged on this day, so that they can go to the clinic and show them. And then we also have our case management call the clinics and verify with them that they are able to come back and that they've been in the hospital this long. So we kind of try to put in a little fail safe there that both the patient and the clinic already knows. So going back to our fictional patient, Danielle here, another concern that she's experiencing, she's in the hospital for a long time, and she feels like providers, nurses, staff are treating her with stigma and are not giving her the same respect that somebody gets that does not have an opioid use disorder. So sometimes when she hears nurses talk about her, she hears them call her an addict, a drug user. One of the new doctors asks her, "How long have you been clean?" She's told that on admission, her urine was dirty for heroin. So, one of the other providers tells her that Suboxone really is just trading one drug for another. And she feels a lot of shame and considers her drug use a moral failing, especially because society has reinforced that in her by her, for example, losing custody of her children. So she really struggles with the stigma that she's experiencing. And it's really complicating her hospitalization that already is difficult due to being away from her life for 6 weeks and undergoing multiple painful procedures and being in early recovery from her opioid use disorder. So one of our big goals as the Addiction Consult and Education Service is to reduce stigma. And what we try to educate other providers and nurses and other staff in the hospital on is to use patient-centered language and language of recovery. So we don't call addict. We don't use that word. It feels even wrong saying it in this presentation. We say this is a person with an opioid use disorder. This is a patient who uses drugs. This is a person who injects drugs. So putting the person first. Instead of saying your urine was dirty for heroin, we use the words positive for heroin. We explain that Suboxone is actually the standard of care to treat opioid use disorder and is a medication to treat opioid use disorder. So it's not like trading one drug for another. We explain how it has shown to reduce all-cause mortality. We reiterate that opioid use disorder is a medical condition and should be treated just like diabetes, hypertension, heart failure, and other medical conditions where we don't blame the patient. We try to really educate others. And even if you just hear in the hallway someone saying something that you think really shows stigma, maybe saying, hey, why did you just say that? Or did you know that it can cause this and this? And maybe we should say this instead. And then we also try to learn from our patients. As Dr. Weaver said, this is a learning process for all of us. And we might have all said something at some point that could have been considered stigmatizing by a patient without us knowing. And a lot of the language that is very stigmatizing, unfortunately, has made its way into popular culture in a way that we might not even think about using a word twice. And our team is really a multidisciplinary care team, and our patients benefit so much from having this multidisciplinary care approach. So we have a provider, so either a physician or a nurse practitioner that will see the patient and do the assessment that Dr. Weaver outlined and start the medication. But then we also talk to the nursing staff and make sure that they know how to administer the medication appropriately to the patient, to really make sure that the Suboxone is taken under the tongue instead of swallowed, that a patient holds their saliva afterwards to give good chance for absorption so the medication can work. And then also, once again, to talk to them about the stigma that maybe they are showing without meaning to show. We have a harm reduction educator and our nurse navigator who does fantastic work talking to our patients about harm reduction. We have a social worker, we have a peer support specialist that is herself in recovery and talks to our patients about what recovery means and some of the challenges they might encounter. We have a counselor and therapist that also meets with our patients. There's group therapy. Before COVID, we used to actually offer groups in the hospital. Hopefully we can bring that back soon, but there's also the opportunity right now to do a lot of these groups virtually through your phone in the room. And there's, of course, a big community support network that we are trying to connect our patients to, even while they're here in the hospital, especially now with attending meetings virtually. Harm reduction is very important to our work. As Dr. Weaver mentioned, we screen for HIV, we screen for all the hepatitis and for sexually transmitted infections. And we also encourage vaccination for hepatitis A and B if a patient is not immune. We, every patient we see, we discharge with naloxone, and we educate patients on how to appropriately administer it. We also educate staff on it, and I will talk about that in a little bit. We provide information about the local syringe exchanges. And then we also talk about safer methods of use. And Dr. Weaver and I do a little bit of that, but depending on the situation, our nurse navigator is really, really good at that. So some patients, you know, are really good at using safe water supply, using a new syringe every time, but they might not know that everybody has natural skin flora that has bacteria in it that they might be introducing to their bloodstream when they inject. So then we talk about cleaning off their skin with an alcohol wipe prior to injection, just as an example. And that is obviously to minimize the risk of infection. To fight the overdose crisis, we talk about fentanyl testing strips or using a test dose, so a smaller dose of your drug supply before you using, to make sure that there's not a lot of fentanyl in it. And we talk to our patients about never use alone. So that's just in general speaking about don't use by yourself, make sure somebody else is there that has naloxone in case there is an overdose that occurs. But we also talk about there is actually a website called Never Use Alone that patients can call if they're alone. It's a hotline that will stay on the phone with them. And there's multiple, so this is like a safer injection kit. So we put some of those together too. So as you can see, there's some filters that are better than using like a cigarette butt or something like that. There's some cookers that I used one time. There's some alcohol swabs in there. There's something to tie off with. The little blue things on the side is the sterile water that can be used to prepare the injection. And a lot of the syringe exchanges, unfortunately, don't hand out sterile water. There is syringes. So ideally, you know, one syringe for every injection, but we can also educate patients about how to clean syringes if they don't know or if they are not able to access a syringe exchange regularly. And then also where to put the syringes safely. So that's that container here, that red container. And there's multiple apps that we can talk to our patients about. So there's different ones that I'm going to go through. And the beauty of it is most of these apps really meet the patient where they are. So there's some that, automatically have a countdown timer that if you don't pause, will call someone and send them to their location. There's others that will have to call somebody to check in with you, really patient-centered and meeting the patient where they are. So Lifeguard is another one. And I think you will have access to these slides so you can read what each app does in particular. And you can also just download them on your Android or your iPhone. Be Safe is another one. So this one, this is really an important one that shows how patient-centered it is, because they talk about the patient can decide if they want 911 to be called or not. And here is a whole smorgasbord for you to pick from for an app. There's drug overdose coaches that are available that, teach you how to react to an overdose if you find someone that has experienced an overdose. And then there's also some linkage to care websites for somebody that is maybe seeking care for addiction treatment. Okay, now let's talk about Narcan or naloxone. So this is the type that is prescribed by our pharmacy. So as you can see, it has a single applicator for one-time use that goes in the nose, and each packet has 2 of those applicators in it. So it is really important to recognize an overdose. And I mean, I know I'm speaking to an audience that really knows that, but what we see a lot of times in the hospital is that if a patient declines, maybe that is the only thing that gets thought of if somebody has an opioid use disorder, or it doesn't get thought of soon enough. So that's where we do a lot of education too on our team. So to recognize an overdose, we talk to people about actually measuring the respiratory rate yourself. Because a lot of times if a patient is on the monitor, a respiratory rate will be displayed, but that respiratory rate might not be accurate. So we ask providers to count the respiratory rate themselves for 15 seconds and multiply it by 4. Look at their pupils. If a patient has experienced an opioid overdose, their pupils will be pinpoint. If they don't have pinpoint pupils, this is probably not an overdose from opioids. And then see if they're over sedated and see if they're able to protect their airway. And then we talk to our providers to administer it really if their patient is unable to protect their airway and experiencing severe hypoxia. And this is the difference between an inpatient setting versus an outpatient setting. So our patients in our inpatient setting, those are going to be patients that are opioid tolerant. So a lot of times if you give them full dose naloxone and send them into withdrawal, that's a very miserable experience. So the patient gets acutely very, very sick with diarrhea, having the worst flu of their life, and they just feel awful. So what we try to educate our providers on is to not give the full dose, but instead give small doses through the IV, and then monitor the response of the patient. And if they need to, they can always give more. But that way a patient's overdose is being treated and reversed without acutely making a patient sick. And the benefit is in the hospital setting, this patient is monitored. So this is a patient, that depending on how sick they are, we can even move them to an ICU setting where they might have 1-on-1 or 2-on-1 nursing ratio where they can be monitored. So there is no need to acutely make a patient sick. We also encourage all the providers to call rapid response as well so that they have some help available. And rapid response is nurses that are specifically trained to help with emergency situations that will come to bedside. In an outpatient setting, there's a similarity. If you find somebody that is down from an opioid overdose, you also want to call 911 because you want to call help, just like we call rapid response for help here. But the difference is in an outpatient setting, this is not a monitored setting. And if you happen to walk into a bathroom and find somebody that has overdosed, you don't know anything probably about their medical history. So that's when you use the intranasal spray, and that's 4 milligrams. So you can see the dosing difference here. You want to place a patient in the recovery position. And like I said, each of those boxes comes with 2 applicators, so you can repeat it if there's no response. The reason why you want to put a patient in a recovery position is in case they vomit. You don't want them this to go down their airway and for them to suffocate from their own vomit. So this is how you administer Narcan in an outpatient setting. And so what we talked about in our inpatient providers, like I said, it's important to recognize an overdose, but it's also important to not automatically assume that everybody that has an opioid use disorder, that all of a sudden has a decline in clinical status, actually suffered from an overdose. So there's other things that can cause this change in mental status. And I mentioned a few here for our more medical people. So, if their blood sugar is low, if they have an acute intracranial bleed, especially if they have endocarditis, they're at higher risk for aneurysms from that. If they have other medical conditions, it could be decompensating, so cirrhosis, scarring of the liver. If they have COPD, they could be retaining CO2. They could be bleeding and hemorrhagic shock. So this is just, their sepsis, their infection could just be getting worse. So this is just like a small example of some other things to keep in mind, and where it's really important to not let your stigma dictate you and only treat one thing and have premature closure on what you think the diagnosis is, because that's how you can really harm a patient. So what I tell learners or other providers here in the hospital is, if a patient is speaking, if they're protecting their airway, if they're moving their extremities, this is not an opioid overdose that at that time needs to have naloxone administered, because all you're going to do is make a patient very, very sick, very angry, and more likely to leave the hospital. All right, so that concludes my portion of the talk. So going through our learning objectives and kind of reviewing, Dr. Weaver gave a lot of statistics about how opioid use disorder and hospitalization are linked, and how infections have been rising as a cause of hospitalizations. We talked about how a patient that is hospitalized undergoes the diagnosis of treatment for opioid use disorder, and how we treat opioid use disorder in the hospital setting. We talked about managing opioid withdrawal. So that's when we talked about the COW score and about starting buprenorphine. We talked about our comprehensive risk assessment. So that's when Dr. Weaver reviewed with Danielle her injection practices, but also did testing for HIV, hepatitis, STIs. We talked a lot about pain control during the hospitalization for both patients on Suboxone and patients on methadone. We talked about stigma our patients face and how we can be allies in fighting the stigma. And then we talked briefly about some harm reduction strategies. So thank you very much for listening to our talk. And we'll take a few questions now, and then next week we'll have a whole hour and a half for questions. I think there's some.
Thank you. Yeah, so thank you so much, Dr. Weaver and Dr. South. We did have one question, and it says, do you routinely prescribe PrEP for HIV and HCV? And if so, what follow-up is arranged when you do?
That's a great question. We do not, unfortunately, but I think it is a practice gap. I think, one of the challenging natures of practicing here at the hospital is over 50% of our patients come from outside. So we get transfers, and then linkage of care and having the patients continue to be prescribed PrEP. But I have had conversations with the infectious disease division chief about PrEP, but I think it's a big practice gap, and I know in some communities it is prescribed, and it is. I think I was actually just reading an article the other day about an HIV outbreak in West Virginia because of that. So I think it is. I think that's a great question, and it is something that we've thought about.
So if you have a question, feel free to put it in the chat, or you can, we have one right here. Would you briefly explain microdosing buprenorphine just a little bit?
Yeah, so so we actually just started a microdosing protocol earlier this academic year. And basically what that means is, as we talked about, is a patient's receptors, if they have are saturated by full agonists, so something like oxycodone or morphine. And if you give them a bigger dose of buprenorphine, all of that gets displaced all at once. So what we do is we give very, very, very small doses of buprenorphine over a 1 week period, and that we slowly increase each day. So, and at the same time, we continue the full agonist. So we continue the oxycodone, we continue the morphine or whatever they are on. And the goal is to displace small parts of those full agonists at the receptors with small parts of buprenorphine. So the patient will never feel sick. And a lot of times they don't even, like, when you talk to them, they can't tell that that's what's happening. And then after a week, they are on a regular dose of buprenorphine, and we can just stop the full agonists without them going through any withdrawal. Or, depending on patient preference and what their pain situation is, we can also taper the full agonists. So we've had great success with it. Patients really like it. We do a lot of shared decision making on when to initiate it. One of the limiting factors is that it is usually a 7-day protocol. And while it can be continued as outpatient, sometimes depending on when the patient gets discharged, where they get discharged to, that might be a limiting factor. Did that kind of explain it a little bit?
We got a thumbs up, so I think that's
Perfect.
good.
Wonderful.
Another question is, does UK have a policy for persons who continue to inject during hospitalization, such as chaperones when patients leave the floor? Do you give the safe syringe kits during hospitalization or just upon discharge?
So that's one of our areas that we're really working on with the hospital. We only give the safe syringe kits at the time of discharge, and we are actually not allowed to give out the syringes itself. So we give kind of everything that that person was holding aside from the syringes. What we usually do is we give it at the time of discharge, so that nurses don't think the patient is using in the room. As far as the policy for continue to inject, I personally don't believe in chaperones. I don't know. I'll let you weigh in on that one.
It's a complicated question,
very complicated
and it causes a lot of conflict in the hospital. I think there's no specific policy, I guess.
Yeah. So they're trying to make a policy, but that policy a lot of times involves discharging a patient. And I don't think that that's the best approach. And I think our nurse navigator has something to add here.
So it's been kind of an ongoing process. I think for a little while, UK had a not exactly a formal policy, but they were concerned that if a patient was using in the hospital, that it was a safety risk. A lot of those patients were administratively discharged, right? So they said, okay, you can't be here. That, it turns out, per DHHS guidance, is an ADA violation. So we discussed that with the hospital, with legal. And so at this point, there's some other interventions that are being used a little more frequently than discharging patients. But we do have a lot of, discussion about what is the best way to address that. But at this time, just discharge is kind of not one of those options anymore, thankfully.
Can I just make 2 quick points on that? So one is, again, thinking about sort of the chronic disease model of addiction, one thing that we need to educate our other providers on is, if somebody's in DKA, which is a complication of diabetes, and they go off the floor and they bring back a donut or something like a sugary beverage, right? We are not kicking them out of the hospital, even though they are potentially jeopardizing and making their health condition worse in that moment, right? So there are so many things that we can do in between, the chaperones and administrative discharge to avoid that really bad complication. One of the biggest things that we can do in terms of reducing the risk of patient-directed discharge is starting medications for opioid use disorder, period. That reduces the cravings, the urges, the withdrawal symptoms that often are triggering in-hospital use. And so the first thing that I talk about with folks where there's a concern for in-hospital use is, hey, even if it's not in the long-term plan, can we try to reduce some of your cravings and urges right now with some buprenorphine, right? So that we can make those decisions about what you want in the long term and what your goals are, without you dealing with these really bad physical symptoms, without the emotions and the symptoms influencing those decisions. And then working with nursing on all the different steps that we can take in between inpatient use and having to discharge a patient. There's a lot we can do.
One of the things I always think about is, why is this patient using? And is there a need that the patient has that we are currently not meeting? And saying that to both the patient as well as the provider, I think a lot of times encourages some good dialogue to see like, what is the need that you're having, that you're fulfilling by using, that we are not meeting in the hospital, and how can we meet that need? And a lot of times, like Dr. Oler said, is starting medication, or changing medication doses, or when the medication is administered, or how that they're not letting it dissolve in their mouth long enough under the tongue. So that's a conversation, I think, like using that line can be very beneficial with both the patients and the providers. And maybe then, after you talk to both of them separately, bringing them in the room together and encouraging a conversation, kind of being a mediator for that. A lot of times there's lots of emotions involved. So it's a difficult thing to do sometimes, but if it works, it's really beautiful.
Yeah. I guess I went back to the opioid withdrawal slide just because I think this is what prompts a lot of in-hospital use, like Dr. Oler mentioned, opioid withdrawal and then cravings. So understanding that a patient is very, very ill, and maybe that's why they return to use, or maybe it's the chronic phase of withdrawal, and they're still, it's still part of the disease process of opioid use disorder, and recognizing that. And I think having a conversation with the patient of why they were triggered, I think having a conversation with the nursing staff about that this is a medical condition and this is something that happens with patients with opioid use disorder. And I think one of the roles as us, as part of the addiction consult team, is actually bringing things down a level and trying to calm everyone down and take a deep breath and explain that this, although it can be quite emotional and challenging and very scary for nursing staff, because they're afraid, a lot of nurses are afraid a patient will overdose in their room or in their bathroom, explaining that this is a disease and this is sometimes what happens with the disease of opioid use disorder. And when they're, discharging the patient from the hospital is not going to make it better. And so we need to find a way to make it safe as possible for the patient. And also be frank with the patient and explain why you're concerned of in-hospital use, and really be forthcoming with the patient. I think it helps a lot.
Yeah, a lot of times I tell patients that I'm here to be their ally and to protect them, but there's only so much I can do, and that they need to work with me a little bit on that too, so that they can continue to get care for their infection that they're here for, which is also a lot of times life-threatening. So
if I could just make one comment, I agree with everything that's been said, and also that sometimes people will receive, people will kind of go on autopilot and put someone on a very low dose of an opioid when they're first admitted. And if someone has a really high, if they're physically dependent and have a really high tolerance, they may be receiving an opioid, but still having very significant withdrawal. And then they're miserable, and there's tremendous anxiety and pain associated with that. And so I think helping our colleagues recognize undertreated withdrawal, even maybe before they are receiving buprenorphine, maybe in the initial, maybe they really have acute pain. Sometimes people just need more opioid, and think of it as meeting the opioid debt and allowing people to stabilize and stop feeling so terrible. One of the things we can work on is acknowledging that part of the stigma of taking care of people with opioid use disorders, there's this undercurrent that kind of is much broader than the healthcare system, but that people should be suffering. And we try to change that mindset that when people are receiving healthcare, there is no role for suffering, that our job is to treat symptoms and make people feel better. And in this context, opioids make people feel better, and that's a good thing, because if people feel better, they're more likely to stay and complete the medical treatment that they're in the hospital for. So we need to remove the perception that a medication that makes someone feel better is a bad thing. It's not.